Good evening and welcome this evening to the final of 4 webinars jointly presented by the PSA and the Aged Care Quality and Safety Commission. My name is Melanie Roth and I'm speaking from Gadigal country. In the spirit of reconciliation, I acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. I pay my respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people today, including those who are with us this evening. The Aged Care Quality and Safety Commission received funding in the 2019-20 budget to address the use of chemical restraints and the inappropriate use of antibiotics in residential aged care facilities. These issues were highlighted in the Royal Commission and they're also specifically mentioned in the Aged Care Quality Standards. This budget measure has funded, among other things, the Pharmacy Outreach Project, which aimed to educate aged care staff about matters they identify as needed at their service. And those issues have included, of course, the overuse of antipsychotics, chemical restraint and antimicrobials. Now, I'm just going to show you an image, and part of the reading material that came suggested with this webinar is the case study that was presented to the Royal Commission of Terry Reeves. And I think that this is a poignant and frankly distressing example of somebody photographed just before they go into residential aged care and after a significant time where chemical restraint was used inappropriately. And if anybody ever needs reminding of why this matters, I suggest that you show them this. So one of the other works we've done is the work with OPAN called Medication It's Your Choice, the Older Persons Advocacy Network, which really is aiming to empower consumers to understand their own medications and informed consent. So I do commend you to that. I hope you take the 6 minutes to watch the animation because I think you will find it useful in your discussions and your education sessions as you go forward. But I'd like to introduce now someone who probably needs none to many of you, as Professor Sarah Hillmer. Sarah is the Head of Department of Clinical Pharmacology and Senior Staff Specialist in Aged Care at Royal North Shore Hospital and Conjoint Professor of Geriatric Pharmacology at the Northern Clinical School Faculty of Medicine and Health, University of Sydney. So Sarah, can you please tell us about the effects of anticholinergic and sedative medications in older people?
Thanks very much, Melanie, and thank you all for coming tonight. Look, I think that picture actually shows you the effects loud and clear. The effects of anticholinergic and sedative medications are basically to exaggerate the detrimental effects we see of aging. And that's not surprising because as we get older, we have less anticholinergic transmission just as a normal part of aging. So anticholinergic medications basically make us look older. And I think that's why a lot of people actually have a lot of trouble recognizing anticholinergic effects because they think, the person's just old. And what I really want to impress tonight is that if you as pharmacists and we as doctors can think, hang on, maybe they're not just old, maybe there is actually a reversible medication attributable cause here, then we can take a person who looks like that poor man slumped on his couch back to the guy who's sitting up and talking in front of his TV. So to go into this in a little bit more technical detail, we see medications with anticholinergic effects used for a wide variety of conditions, including Parkinson's disease, depression, COPD, psychosis, urinary incontinence, and hay fever. And because there are so many different medications that have anticholinergic properties, they can be quite hard to recognise in day-to-day practice. Older people are more susceptible to drugs with anticholinergic and sedative effects. That's partly because, as I mentioned, they just have less reserve in their system. They have less anticholinergic transmission in the first place. Pharmacodynamically, people are actually more sensitive in terms of their GABA system and their opioid system to sedation. But in addition to that, they also have all the pharmacokinetic changes that we're familiar with in old age. And particularly the reduction in clearance means that if you give an old person a standard maintenance dose, they will wind up with a much higher effective concentration in their bloodstream, and therefore an exaggerated effect of their anticholinergic and sedative drugs. The anticholinergic effects that we see in older people, and this is straight out of AMH aged care, look very much like exaggerated effects of aging. We see cognitive effects like delirium and confusion. We see constipation. We see dry mouth that can result in problems with dental caries. We see dry eyes. We see impaired sweating, which can be a big problem for older people on hot days, where older people are already not very resilient to any sort of rocking of their boat or change in homeostasis. So while they might be prone to react badly to heat in the first place, give them anticholinergic medicines, they can't even sweat, and they really have very bad outcomes. Anticholinergic effects include urinary retention, as well as an increased risk of falls, and tachycardia, which can be problematic for people who have underlying ischemic heart disease, and then can sort of almost precipitate an episode of acute angina or a myocardial infarction. So where possible, we try to avoid using anticholinergic medication in older people. And I guess when you're thinking about medicines, and I may have said this to some of you in previous talks, and I apologise if it's repetitive, one of my favourite frameworks is the one from the Institute of Medicine in the US that Mary Tinetti, who's a very famous geriatrician, came up with. And that's the 4 M's. So you think about what matters to the person, and you think about their medication and how it can help them achieve what matters to them, how it can help them optimize mobility, and how they can help them with their mentation. And if you take anticholinergic and sedative medicines, and particularly if you take them together so you get their additive effects, then you will wind up really harming someone's mobility and mentation. And those are generally the things that matter to people. If you can think and you can move, then you can enjoy the best quality of life you can with the people around you. When it comes to sort of thinking about whether you're going to use an anticholinergic medicine or review an anticholinergic medicine, often there is an alternative treatment. It might be a non-pharmacological treatment or a treatment without those effects. If you really need to use a medicine with anticholinergic or sedative effects, for example, you've got a person who's just had an acute injury and has a lot of pain and you really need to use an opioid, then see if you can minimize the dose, use it for the minimum possible time, and try to withdraw any existing anticholinergic or sedative medications as quickly as possible so that their total load doesn't move up too much. We see very clearly that there's a cumulative effect of anticholinergic and sedative medications on people's cognition and their physical function. The more total exposure they have to those drug classes, the more likely they are to have delirium, to be less likely to interact with other people and less able to interact with other people, unable to get up and walk, more likely to fall, more likely to have fractures, more likely to be frail and become more frail, more likely to have problems with nutrition and dentition and dehydration, pressure areas, go in and out of hospital, and to die. So it really is imperative on us as the guardians of their medicines to make sure that those side effects are recognised and that exposure to those drug classes is minimised. One of the other things to think about when you're trying to minimise these drugs is balancing their well-characterised side effects against their fairly limited effectiveness, particularly when they're used in older people and used chronically. And good examples are things like opioids for chronic non-cancer pain, benzodiazepines long-term for sleep, antimuscarinics for people with mixed incontinence. They might work a little bit for people with urge incontinence, but pretty much everyone in a nursing home has mixed incontinence, has a bit of urge, a bit of stress, and a lot of functional difficulty getting to the toilet. Antidepressants for people living with dementia, and antipsychotics for BPSD. So you've got often drugs which you're reasonably confident don't help much and hurt. So it's a really great place where you can make a difference by identifying those drugs and those potential adverse effects and recommending that they're withdrawn and you can potentially see the person get better. I just want to take the last couple of minutes to tell you a story about a lady who I saw in hospital. This This lady had been in a residential aged care facility for about 2 years, and she could walk with a frame. She could talk to her daughter, who visited once a week. She did have urinary incontinence. Her medications were mirtazapine for long-standing depression, omeprazole, atorvastatin, metformin, irbesartan, and paracetamol. Now, she, between visits with her daughter, had a fall and complained of very painful back. A GP reviewed her and didn't think he could give her a non-steroidal anti-inflammatory drug. She had bad chronic renal impairment. She had heart failure. She had something going on in her gastrointestinal tract, which had led to her being on the omeprazole, and decided that he would just put her onto a buprenorphine patch. The daughter came back the next week, and her mother couldn't get out of her chair, couldn't engage in conversation, didn't even seem to really know her. The staff said, "Oh, look, she's old. This sort of stuff happens," and the daughter insisted that her mother get sent to hospital. When she was in hospital, we noted that she had this new buprenorphine patch by talking to the community pharmacy, and we took it off. And over a couple of days, she returned to baseline and went back to her aged care facility. So I think it's those stories like the man that Melanie showed us, and this lady who I've told you about, that really remind us that just by looking really carefully at someone's medicines, we can tell that sometimes they're not just getting old. These are just side effects of medicines that look like you're just getting old, but are in fact reversible. And you can make a huge difference in someone's quality of life by identifying those medication-related problems and doing something about it. Thanks, Melanie.
Thank you, Sarah. What I would like to go on to now is this rather exciting tool that you've developed, which helps clinicians recognise the effects in individual patients. And this is exciting to me as it can guide both conversations and recommendations for deprescribing, conversations about informed, that inform the informed consent. So can you explain the Drug Burden Index tool and how it came to be?
Thanks, Melanie. Look, when I finished my geriatrics training and my PhD at Sydney Uni, I went over to the National Institutes on Aging in the US, and I worked with one of the fathers of geriatric pharmacology, a man called Darryl Abernethy. But together we worked out that while it's all very well for geriatricians to run around saying, once you're on 5 or more drugs, you're in trouble, and they're absolutely right. It didn't really help you at the point of care, sort of working out exactly which drugs are causing trouble. And we thought that because we were both clinical pharmacologists and geriatricians, we could probably do better by thinking about not only the number of drugs, but the type or class of drugs and the dose of drugs. And it was pretty clear that we needed a tool that could help us actually identify a person's total load to medicines that would slow them down physically and mentally. So we came up with the Drug Burden Index. And the idea of the Drug Burden Index was to measure a person's total exposure to medicines with anticholinergic and sedative effects. And those are the medicines that would impair your function physically and mentally. And those are the side effects that people just don't recognise. You do a standard medication review and an intern can tell that an anticholinergic is making you bleed and insulin is making you hypoglycemic. But it takes a little more thought to recognise all the different drugs a person might be on with anticholinergic or sedative effects and work out their cumulative impact. We thought long and hard about how we would do this calculation, and we thought about whether we should weight the drugs depending on how sedative or how anticholinergic they were. But the data on that was really pretty soft, for want of a better word, and highly conflicting. And it was hard to really get an accurate measure of how anticholinergic or how sedative something was. So we decided instead to use the dose-response equation, understanding that the higher the dose you're on, the more of an anticholinergic or sedative effect you will have. So when we work out the Drug Burden Index, we look at a person's medication list. We look at all the drugs that have an anticholinergic or sedative effect. And for those drugs, we look at the daily dose the person takes, and using the dose-response equation, we substitute that for the dose for we put that into the equation. Instead of the dose required to get 50% of the effect, we use the minimum registered adult dose, figuring it's somewhere on the dose response curve and probably around 50%. And we get a number between 0 and 1 for every drug that a person takes with an anticholinergic or sedative effect. And then we add them all up to get the person's total drug burden index. So if a person is taking the standard registered daily dose of a drug with an anticholinergic or sedative effect, then for that drug, they will get a score of 0.5. And we wind up with a person's score. Now that went on to be validated initially in observational sort of epidemiological studies that we did in the US, and then I did again when I came back to Australia, and subsequently has been validated really around the world. And it turns out that the higher your drug burden index is, the more likely you are to have not only impaired physical function, which is what we initially validated against, and cognitive function, but also the more likely you are to have falls, hip fractures, be frail and become frail, wind up in hospital, wind up in a nursing home, and to die. So we felt the evidence was pretty strong. I've also subsequently done some interventional studies in mice, because you can't really do them in humans, where we give mice polypharmacy with 5 drugs that either have a drug burden index of 0, 0.5 or 1.5. And we saw what happened when we treated them from middle age to old age. And it wasn't the number of drugs, it was the high drug burden index, the type of drugs that actually caused them to become frail. And what was really nice to see was that when we randomized them and deprescribed or withdrew the drugs, the mice actually got better and became less frail and better able to do their activities of daily living, like make a nest. So we have good observational data from around the world that suggests this actually is a valid tool, and we have really good preclinical data that suggests that not only does high drug burden index cause frailty and functional impairment, but that it's reversible with deprescribing. So with that body of evidence behind us, we decided it was ready to be used as a clinical risk assessment tool. And then the rate limiting step became the calculation, because while I can sit here and explain it to you, you can imagine that doing it at the bedside is not quick. And I was very fortunate to have Lisa Colagino-Donnell, who is a PSA member, come and do her PhD with me. And together we developed the first drug burden index calculator, which we've subsequently put into software that's now available. I'll talk about it a little bit later in the community, and also have built something into the hospital software as well, so that you can see it at the point of care. And if you can see the person's drug burden index, you know who's at risk of having that medication-related functional impairment. And then you can go in and have a look, see which drugs are likely to be contributing, because as I said earlier, it's not always easy to pick the anticholinergic and sedative drugs. And then think very hard about how badly the person really needs this drug. You can see that it's hurting them. Is it helping enough to make it worth it? And that's a conversation to have with your patients and their caregivers. Do I have time for one more story, Melanie?
Yes.
Okay. So this is another story, and it's a similar story. This is a story about a lady, again, in a nursing home, and her family said that she looked a lot worse than when they came a few days ago. She was less responsive than usual. She couldn't walk around the corridors with their support anymore. And this time, the nurse sort of went back and had a look at the notes. And she noted that the resident had been scratching her skin and had been given a PRN sedating antihistamine for the last 3 days. And her other medicines were citalopram, simvastatin, irbesartan, and vitamin D. So both the sedating antihistamine and citalopram were contributing to her drug burden index. And that then would allow you to see, hang on, here's a problem, and go back and look for that medication-related harm and to do something about it. For example, if you've got itchy skin, there are a number of things you can do before you jump in with a sedating antihistamine. How about some looking for the cause and maybe a little topical treatment first? So that's what happened in that situation. But I guess had there been a DBI calculator or a drug burden index calculator on hand, then ideally when you started a new drug, you would add it to the calculator and you would instantly see that drug burden index go from sort of being moderate with just its citalopram up to very high and a nice bright red color once you added in the antihistamine. And then you actually might think, hang on, what am I doing here? Is this really necessary? I could cause some harm. So at this stage, it's something that that is not used in day-to-day practice, but certainly could help us if we could use it prospectively when we're thinking about prescribing, and certainly is helpful in the medication review setting. Thanks, Melanie.
Thank you, Sarah. We'll certainly be coming back to you. There are a couple of questions coming through in the chat, so please keep them coming. As previously, if we don't get to them by the end of the webinar, we will answer them individually, and they're certainly helpful. They're helpful to be guiding our future work too. I'd like now to introduce you to Dr. Lin-Lee Lim. Lin-Lee is a specialist infectious diseases physician based in Melbourne. She works at VICNIS in the Doherty Institute and is also a much valued consultant for the Commission at the moment. Lin-Lee, can you give us an overview of what antimicrobial stewardship, or AMS, actually is, please?
Thanks, Melanie. Well, broadly speaking, antimicrobial stewardship is having an organizational approach to strategies that focus on safe and appropriate use of antimicrobials, reducing patient harm, and also focus at preventing and containing antimicrobial resistance. And the activities that support antimicrobial stewardship are laid out in the Australian Commission for Safety and Quality Healthcare AMS book. For those of you who haven't seen it already, take a look in particular at chapters 2, which is covers organizational elements of an AMS program, and with particular focus in an aged care setting, chapter 16. As well, in Australian aged care services, the aged care quality standards that Melanie has already mentioned provides information to providers around compliance requirements. And the 8 quality standards, at the heart of the standards is consumer dignity and choice. And there are also 2 that I want to point out that specifically relate to antimicrobial stewardship. So we have standard 3, requirement 3G, which is around minimization of infection-related risks through implementation of infection prevention and control, but also antimicrobial stewardship. So practices to promote appropriate prescribing, and also measures to reduce risk of increasing resistance to antibiotics. And so providers are asked to reflect as to whether their services can provide evidence on care strategies used to minimize the risk or the need for antibiotics, such as measures to reduce the risk of urinary tract infections or treat minor skin infections. They're also asked to reflect on how does the organization support their workforce to understand and promote appropriate prescribing of antibiotics and reducing the risk of increasing antimicrobial resistance to antibiotics. Standard 8, requirement 3E, is around effective organization-wide systems, including a clinical governance framework that covers antimicrobial stewardship and covers prevention, management, and controlling of infections and antimicrobial resistance. And reflective questions around this include strategies and practices to make sure that antimicrobials are prescribed according to best practice guidelines, that we have evidence of a systematic approach to audit and data comparisons to support improvements in clinical care, that the workforce can describe their accountabilities and responsibilities around effectiveness, safety, and quality of the clinical services that they provide around infections and antimicrobials. And also, very importantly, consumers say that members of the workforce discuss their clinical care with them, including risks and benefits of any clinical treatment and the appropriate use of antibiotics.
Thank you. So for pharmacists who are working in aged care and who may be asked to assist and educate providers in improving their antimicrobial stewardship, can you explain why antimicrobial stewardship is so important in aged care services?
I think many of you will be really familiar with some of the things that I'm about to say. You will already know that antimicrobials are commonly used in an aged care setting, far more commonly than in community setting for similar age group. And at any point in time, 8 to 9% of residents will be on an antimicrobial. 70% of residents are prescribed at least 1 antimicrobial course a year, and the median number is usually 3 courses. and 20% of prescriptions are for prophylaxis. And this is really staggering when you consider there are very few guideline-approved indications for long courses of antibiotics for prophylaxis. And Janet Sluggett and her colleagues recently published a nationwide study looking at prescribing practice in aged care services around Australia. So they looked at a time period of between 2011 to 2016, looked at over 300,000 residents. And what it showed was there was a wide variation in antibiotic use. When you looked at the lowest quartile, use in lowest quartile facilities, we had a median of about 54 DDDs per 1,000 resident days. And when we compared it to the highest quartile, the median was nearly double that, 106 DDDs per 1,000 resident days. As well, we know that inappropriate antimicrobial use is an area of improvement. Year after year, Aged Care National Antimicrobial Prescribing Survey, Aged Care NAPS, has shown data that shows similar problems with prolonged duration of prescriptions and high rates of PRN prescriptions. We also know from annual data published through the Australian Commission in the form of oral reports that national surveillance reports of antimicrobial resistance rates are higher in aged care settings than in community and even hospital settings. So if we look at last year's report, the 2021 report, for MRSA, rates of MRSA in aged care settings was 26% versus hospitals, 22%. E. coli, cefazolin resistance of E. coli in aged care settings, and we can probably from that extrapolate cefalexin resistance, rates of resistance in aged care, 35% versus hospitals, 20%. As well, the Commission recently looked at their complaints data for financial year 2019 to 2020. And what it showed is that of all medication-related complaints, complaints around infections and antimicrobial use is common. 10% of complaints for all medication-related complaints related to infectious diseases and antimicrobials, and it actually as a group represented the third most common source of complaint after pain palliative care and sedative medications.
Thanks. So what I'd like to do now is go back to Sarah, now that you've had a bit of a break. I want to go back to the Drug Burden Index tool now. So how can pharmacists access this if they're interested in using the tool in their own aged care practice?
Thanks, Melanie. We have developed a software platform called the GNEBS, or Goal Directed Medication Review Electronic Decision Support System, which is freely available to all registered Australian health professionals. And if you just search it online, you'll find it. NPS MedicineWise are also promoting it through their academic detailing for the current module they're running on anticholinergics. And if you look at GNEBS, you'll see that there are 3 tools in it. There is a drug burden index calculator and report, and you can use that for any of your patients. You do need to get consent because this is being run through university. So you can enter the person's drugs from a drop-down list, their dose and the frequency. It also asks you to enter information on whether the person has any potential anticholinergic or sedative side effects, like the ones I mentioned before, sort of being drowsy, cognitive impairment, urinary retention, constipation, falling over. The calculator will then calculate the person's drug burden index, and it will show you their total score and show it to you very nicely on a sort of gas gauge from green being 0 through orange 0 to 1 to red more than 1. And it will give you a table at the bottom which has each of the person's drugs, and you can populate your recommendations and the reasons why. So that's in there. The other things that are there are 2 things that we thought would make it, would be helpful and help people basically use the drug burden index in practice. So there's a tool on assessing the person's goals of care. And when we ran this through our national cluster randomized controlled trial, and thank you to those of you who might have participated in that when we did an in-home medicines review, we found that the main feedback from pharmacists was that asking about goals of care was actually not something that pharmacists were always comfortable with doing, and not necessarily part of people's usual training or practice. So we've got a very structured version in the current version of GNEBS, which has questions about the person's global goals of care with drop-down options and, of course, an other, and also medication-related goals, which again is fairly structured and allows you to run through, I guess, what the person is trying to achieve when you're doing the medication review. And that's, we thought, would be really helpful, because if you see someone, they say, look, what I really want to do is think as clearly as I can and walk around as well as I can, then you know you're trying to optimize their function, you're trying to minimize their drug burden index, and the two go hand in hand. The other tool that's available on that platform is the Patient's Attitudes to Deprescribing questionnaire, which Emily Reeve developed. And again, sometimes getting the person or their carer to do that. We have the older person's version, the carer's version, as well as the simplified version for people living with dementia. Just highlights to you as the clinician what the person thinking about potentially stopping one of their anticholinergic or sedative drugs, and what their major enablers or barriers might be when you're having a conversation. So it is available, and we would love people to use it. As I said, you do need to get consent because we do collect health data on that, and it's a platform held at Sydney University. But it's out there, and we're really hoping that doctors, nurses and pharmacists use it. We're working with Melanie and the team at the Commission at the moment to make it available in residential aged care, and potentially something that nurses in residential aged care could help with populating, so that the data's in there and ready to view. And then if you've got a lady like the one I mentioned who sort of started the antihistamine, you could prospectively see, hang on, what am I doing here? And you would know that you're going to run into trouble rather than waiting until you actually did. So that's the access at the moment. Lisa and I have no desire to long-term run a software company, and we're looking at ways that we can get this integrated into existing software platforms. And as I mentioned, it's in the New South Wales Health Electronic Medical Record and currently being tested at a couple of LHDs.
Closely related to that, Sarah, one of the questions that's come through is how it's from a pharmacist who's using it and is a big fan, but was wondering how we can raise the profile amongst GPs, given how powerful it is in conversations with patients.
Yeah, look, I really think that this NPS Medicine-Wise program on anticholinergic burden will raise its profile amongst GPs. It's very much part of the education package. They're not only telling people about using it, but also doing audits on the Medicines Insight data, giving GPs feedback on the DBI amongst the population of patients that they treat against various benchmarks, and looking at whether people with high DBI are getting referred for HMRs and other patterns like that. So I think that this program should really raise awareness amongst community practitioners.
Thank you. And now we know that pharmacists don't hold the prescribing pen, but they are potentially extremely influential in that space. So how would you advise pharmacists to initiate and facilitate deprescribing?
Look, pharmacists are absolutely custodians of medications. They're the ones who are really focused on medications, who have that as their main priority and have a lot of roles in deprescribing. I'll just list some. So I guess the first thing to do is, as we said before, identify the person's goals of care, trying to work out what the priorities are for the person, so that you can make sure that their medicines match their goals. Then pharmacists, who are much more accurate than any other health professional at actually using medication data, would be the ideal people to identify high-risk prescribing, and particularly if it came to in calculations like, say, drug burden index, and using those as clinical risk assessment tools. Pharmacists are the ones with the skills. Pharmacists are also really good at identifying adverse drug effects, and particularly those adverse drug effects that others may just mistake as being just getting old. So pharmacists are probably much more likely to have at the front of mind, hang on, could this symptom be an adverse drug effect? Because they're thinking about drugs, and pointing those out to the team is a really important start when thinking about deprescribing. You've got to recognise there's a problem. Pharmacists are also very good at identifying medicines that might actually be of limited benefit. Pharmacists have a good knowledge of therapeutics and evidence base and guidelines, and just taking that step back and looking at the medication list and at the person's problem list and the person's goals allows pharmacists to say, hang on, yes, this isn't particularly a high-risk medicine in terms of side effects, but what on earth is it achieving here? And that's an important question to ask too when you're thinking about deprescribing. So pharmacists are also very good at recommending alternatives to high-risk drugs or drugs that might be causing adverse events. Again, get good knowledge of therapeutics and just using those basic quality use of medicines principles. Is there a non-pharmacological option here? If not, what is the optimal pharmacological option? I think one of the ways that pharmacists can really have probably the biggest impact is through working closely with the team, working with the patient, with the carer, with the nurses in the nursing homes, and with the GPs and any other prescribers. And I guess talking in a language that those people can understand and with a strong evidence base that is really clear is really important. So tying it back to the person's goals, tying it back to those 4 M's that we spoke about, the medication, trying to optimize what matters for the person, their mentation and their mobility, is a language that the people who look after all the people understand. And having those clearly documented individual goals, which you could use GNEBS or another structure to describe, again, just helps make that medication review patient-centered. So the rest of the treating team and the patient and the carer actually understand why you're recommending what you're recommending. So looking at the person's global goals, their medication goals, and really tying your recommendations to that makes a huge difference. And the other thing that I would hope might be helpful would be using something like drug burden index, where you actually have an evidence-based tool and you can say, look, I can see that your mother's slowed down physically and mentally. I see that she's actually got quite a high load of drugs which have these particular effects, the anticholinergics and the sedatives. And if you look at this calculation, you can see that it's coming up as red, it's high. And if we try reducing some of these drugs, then we might be able to bring her back down to the orange zone. And you might find that she feels better and recognizes you and talks a bit better, which is what she and you would really like to achieve. So talking the language that is patient-centered and evidence-based, ideally with a sort of visual numeric tool, can also be really helpful. Pharmacists, again, with their in-depth knowledge of drugs, can give good advice on how to taper a drug slowly to avoid adverse drug withdrawal events when that's necessary. And that often is necessary with the anticholinergic and sedative drugs. And pharmacists can also give really good advice on how to monitor a person as the prescribing process occurs. So what to look out for in terms of potential adverse drug withdrawal events, what to look out for in terms of return of whatever symptoms the drug was being used for in the first place, and also what to look out for in terms of possible improvement when you reverse what you think might be an adverse drug reaction. And so giving that really structured guidance so people can recognise the impact of the deprescribing is a really valuable role, and a role that pharmacists can do extremely well with their in-depth drug knowledge. So I think those are, those are really the areas where pharmacists can make a big difference. And if I've got time, Melanie, I'll just take those steps through that second patient example.
Yes, you do.
Thank you. So so we think about that lady who had recently started the sedating antihistamine for her itch, and become immobile and confused and drowsy. So what mattered to her was very clearly walking and talking, mobility and meditation. And you could do a medication review and you'd see very clearly that she had a high DBI with contributions from citalopram and Phenergan. And those drugs reduced her mobility and her mentation. As a pharmacist, you can identify her adverse drug reactions. You can see that Phenergan caused the acute decline, citalopram would have a chronic impact. She had quite severe dementia. It was unclear really why citalopram would be there in the first place. It had been commenced for grief several years ago, and no one ever wanted to rock the boat enough to stop it. You could also look at her other drugs. She was on simvastatin, which she had for primary prevention. Probably wasn't causing her any problems, but it does have muscle effects, which can be hard to detect, and probably could affect her mobility even a little bit. And with her mobility being so tenuous, you wouldn't even want to affect it a little bit. And yeah, statins for primary prevention in people over 80 really have very little evidence of benefit. So you could probably deprescribe that too. She was on the irbesartan for blood pressure and some heart failure. And you probably wouldn't rush to stop that one, but you would certainly check her blood pressure and make sure that she wasn't getting terrible postural hypotension, and that could be impacting on her mobility as well. And she was on vitamin D. And I guess since we found that she never went outside, it's highly likely she never got any other source of vitamin D, and probably not unreasonable to leave it there. The pharmacist role is looking for alternatives. Well, yeah, the sedating antihistamine is clearly not step one when someone has an itch. And so you could, talk to the nurses, see if between you could work out the cause of the itch. Have they used a new washing powder? Did she get a new blanket, a new shirt, whatever it might be? And then if she needed something, think about something topical. Talk with the stakeholders, as I said, use that evidence-based language, centered on what's important to her, being able to talk to her family and walk around. Show them the drug burden index, show them how it went from sort of orange to red, and she went from walking and talking to sort of sitting looking vague and tired. And give some guidance on how to taper the citalopram. You don't want to stop citalopram cold turkey, you want to wean it slowly. And give some guidance on monitoring the itch, monitoring her mood, monitoring her behaviour, monitoring her mobility and her mentation, and hope that everything gets better. So those are the really key roles of a pharmacist, with a good knowledge of the patient, or should I say resident, and a good knowledge of drugs, and good communication around patient-centered care and evidence-based medicine can really make a huge difference, and give people the best quality of life they can have.
Sarah, there's another question for you come through, and there is time, I think, in relation to consent, that pharmacists might perceive having to gain consent as a potential barrier. And I guess it's something they're not necessarily accustomed to in the same way that the doctors are. Can you outline what support there is or guidance in relation to gaining consent for using the GNEBS tool, and how you approach that conversation, just briefly?
My understanding is that pharmacists actually have to get consent to do an HMR. And so I think pharmacists are reasonably comfortable with that. But it's very clearly written out. There's a participant information sheet, which really just says that the person's data will be stored on the Sydney, de-identified on the Sydney University server. And you just really have to explain that either to the person, or in the case of many people in residential aged care who may not be competent, to the person responsible. And it's something which I guess, could easily be done before. I guess if you're going into a residential aged care facility and this is a tool that you would like to use as part of your preparation, you could even contact the carers or the surrogate decision makers and say, look, this is something I'd like to do as part of my review. And at the same time as you're getting consent to do the review, you get consent to use the tool. And the tool's not there as a substitute for clinical decision making. The consent really is around the data storage. Thanks.
And there's been a couple of requests for further information on the tool. So if you've got a moment, Sarah, you can put a link in the chat. Otherwise, we will make sure that we send that link to anyone who requests it.
If I can work out how to do the chat, I will. And if not, I'll leave it to you, Melanie. Yeah.
All right, thank you. Look, I'm going to go back to Lynn Lee now with really a bit of a similar problem. So, Lynn Lee, if inappropriate antimicrobial use is known to be a big problem in residential aged care services, what is the role of pharmacists in that area?
Well, I would echo what Sarah said. I think pharmacists have a really vital role to play in terms of improving antimicrobial prescribing in aged care. They're, I think, widely regarded as a source of expertise, and that's by clinical staff on site, GPs, other prescribers, consumers, residents and their families as well. And we're obviously familiar with off-site pharmacy provider activities, delivering pharmacy-related services such as dispensing medications, but also the 2 Commonwealth-funded programs that I'm sure you're all familiar with, the Residential Medication Management Review, RMMR, and the Quality Use Medicines, QUM, programs where pharmacists offer on-site services as well. So RMMR activities, broadly speaking, medication reviews of resident prescriptions with specific recommendations to treating clinician and then following up on these recommendations. QUM activities are much broader in scope and include medication activities sort of from top down. It can be at a medication advisory level, policy level, guidelines, procedures, clinical interface, education, surveillance audit, quality improvement. So things that are relevant to the quality standards that I mentioned before. I think there are some particularly important activities at this point in time that I want to mention that are undertaken by pharmacists as part of QUM activities, which I think really make significant contributions to improvements in prescribing. The first is supporting services in identifying and using best practice and current antimicrobial prescribing guidelines. And for that, I would strongly recommend the therapeutic guidelines antibiotics as the source of truth for up-to-date guidelines around appropriate prescribing by indication, route, and duration. Also promoting the use of dispensing report data as part of monitoring antimicrobial usage, and that can be within the service or if there's multiple services within an organization, peers. Also actively supporting the collection and use of audit data to identify areas of improvement. And some examples of effective audit that come to mind based on GNEBS data that I've mentioned before would be targeting excessive durations for treatment of infections and prevention of infections. So it might be an approach where you flag antimicrobial prescriptions and select for close review of oral antibiotics prescribed beyond 7 days or topical antifungals beyond 14 days. You're pretty comfortable in the knowledge that you're going to have a high yield in terms of making recommendations or identifying inappropriate prescribing, because most guideline-directed durations for treatment of infection indications are up to 7 days for antibiotics in therapeutic guidelines, antibiotics and topical antifungals, 14 days. Another approach might be to target antimicrobials that are charted as when required or PRN. PRN prescribing for antibiotics really, as a general rule, is likely to be inappropriate. PRN prescribing for weeks, months, carried over onto new medication charts can result in antimicrobial resistance and use of an antimicrobial in a way that really confers no clinical benefit to the resident. I would also acknowledge, I think, that there's a complexity in terms of delivering these sorts of activities within the aged care service environment. Integrating pharmacist input and collaboration within a multidisciplinary team. As Sarah mentioned, it's really important to discuss findings, agreed recommendations, identify agreed strategies, but it's balanced also against the fact that it is a really time-pressured environment, and there may be limited opportunities to have these meetings face-to-face or even having everyone in the same virtual space and time. RMMR reviews around antimicrobials are clearly an effective strategy that's been shown, but being able to make a recommendation can be limited by the quality of documentation, the information that's available to you, that allows you to make an effective recommendation. So if the documentation around indication, when the agent started, microbiology culture results are missing, or allergy status, including nature and severity of allergy, that can severely curtail your ability to make an effective recommendation. And we also recognize that ultimately the onus is on the prescriber to accept or ignore the recommendation. Hence, Sarah said, that collaboration, relationships, working with in a team approach is important.
Thanks very much. If we can move on really to tell us what resources are available to support pharmacists in these activities, that would be really helpful, I think.
Yeah. Well, the Commission is really interested in supporting aged care providers to improve antimicrobial prescribing. And this is by a twofold approach. That's by promoting AMS and antimicrobial resistance as an area of focus for improvement in aged care services, as well as increasing resources to improve health literacy of consumers and those involved in supporting residents' health around antimicrobial stewardship. So we launched a suite of resources late last year. These Commission developed resources can be accessed via the Commission website. So go to the Commission website, look for the provider tab and look for the AMS webpage that lives under the provider tab. And these pages will take you to links, a landing page that goes through Commission developed resources, and which are split up into provider resources, clinician resources, and also consumer resources. And there are also links to Commission endorsed resources around antimicrobial stewardship. And there are some examples of Commission AMS resources for consumers that may be useful in pharmacy discussions or clinical team discussions with residents and families. So one is the Commission's brochure, Do You Need Antibiotics? It does provide information, in terms of what you would expect generally in this sort of brochure, benefits and risks of antibiotics, and encouraging consumers to be really proactive in what questions to ask when they're being started on an antibiotic, or even if they've been on one for a long time and they're not quite sure why they're on it. But also it explicitly provides information on what are the limitations of antibiotics. So what don't antibiotics treat? There's no point using antibiotics for a proven viral respiratory tract infection. Some bacterial infections we know are self-limited and get better whether you prescribe antibiotics or not. As well, antibiotics don't work in conditions where you've got harmless bacteria that are acting as colonizers, for conditions where the resident is not experiencing any symptoms or signs. So a classic one would be asymptomatic bacteria or a wound. There is a wound, skin break, but it's not infected. So hence, it does not need antibiotics. And also a key point that we make in the brochure is they are unnecessary when used for prophylaxis. And this in situations where, such as topical antifungals used for months or sometimes years, and they've never been reviewed and with view to stopping. There's also an open webinar that was delivered in August, and there's a link to that from the site on using antibiotics. Well, do I need a drug for every bug? Where a panel of experts explored the issues around antimicrobials, antimicrobial resistant in aged care, and also how older people can protect themselves. And that includes using strategies that are non-antimicrobial related. And the Commission as well has also identified that prescribing for UTI is really a key area for improvement. And to that end, the Commission has developed a suite of resources called the To Dip or Not to Dip campaign. This was launched in November, and if you want kind of like a brief overview of what's in that, on YouTube, the National Center for Antimicrobial Stewardship, Antimicrobial Awareness Week, there was a special session on aged care, and we had a session where we discussed this. To Dip or Not to Dip really is a suite of resources to support services, clinicians, consumers, and also pharmacists, and giving you an opportunity to play an active role in terms of improving use of antimicrobials for urinary tract infections, built on UK's highly successful quality improvement program for improving practice in this area. And when it was used in the UK, astoundingly demonstrated 56% reduction in antibiotic prescriptions for UTI, 82% reduction in number of residents prescribed antibiotic prophylaxis. But also, really interestingly, there was an overall 67% reduction in all antibiotics prescribed in the homes. So that's for all antibiotics, which just goes to show in the UK, and probably similar to Australia, prescribing for urinary tract indications is really contributes significantly to antibiotic prescribing burden. And also importantly, there were no unplanned admissions for urinary tract infections or urosepsis. So it was safe and effective. And indeed, they actually demonstrated reduced calls to GPs for inappropriately diagnosed UTIs. So we've adapted that quality improvement and to an Australian context. And really, the resources that we have on our site includes really education where the focus is on around the concept of asymptomatic bacteriuria, where we're trying to discourage people. And this happens in hospitals as well as aged care and community settings as well, where reaching for the dipstick should be infrequent practice rather than the first step in terms of assessment for UTI. So it's to encourage staff to instead use a clinical assessment pathway instead of automatically reaching for a dipstick. And this clinical pathway is adapted from the therapeutic guidelines management algorithm for suspected UTI for people in living in aged care facilities. And I just wanted to mention briefly a couple of resources that may be of interest to you. One is case-based education for staff, and the audience is nurses and PCAs, delivered by a facilitator. And it was actually developed to be facilitator delivered by pharmacists or nurses. As well, pharmacists may be interested in a to dip or not to dip audit tool, which supports services in collecting quality improvement data around identifying the number of prescriptions for urinary tract indications and reviewing appropriateness with view to stopping. So I think those are just a few resources I want to mention. But in terms of the way forward for antimicrobial stewardship and the Commission recognizes that health literacy is really a quality and safety issue and can contribute to overprescribing of antibiotics for treatment or prophylaxis. Can also contribute to individuals' risk of colonization and infection with multi-drug resistant organisms, and also contribute to multi-drug resistance and multi-drug resistant outbreaks within the local environment and community. So in 2022, the Commission is continuing to focus work in this area. And if you're interested in to dip or not to dip or any of the Commission's AMS work, please reach out to the Commission's pharmacy unit. The email is pharmacyunit@agedcarequality.gov.au. Thanks, Melanie.
Thank you so much. And Lindley and Sarah, for all of your input tonight. Really, really very much appreciated by I hope everyone who's listening. But thank you, pharmacists, for joining us tonight and over the last 5 months. We would really like to emphasise how important pharmacists are in aged care, although I know you know it, but I just want to emphasise that we know it too, and how this group, you, can make fundamental and material differences to systems, knowledge and practice, and crucially to the risks, empowerment and quality of life of individual elderly people whose lives you touch. So please continue to ask your questions, tell us your experiences, including any interesting stories and good outcomes that we would love to hear and pass on. If you see poor practice or you have concerns for the welfare of any individuals, please also let us know, as you may be the only opportunity to enable us to intervene in that person's lives, and concerns of professionals taken very seriously by the Commission. So with that, I'm going to wind up and wish you all good night, and thank you so much for your interest and attendance.